Yes. Okay. So we are first here with our Congress President. We hear first a lecture concerning that embolization treatment, and then we have the live case.
It's very important to emphasize regarding this topic. Thank you very much, Professor Matthias. It's very, very important to emphasize that not all the embolization materials are equal. So there are different kinds of coils, particles, glue like glue bran, also some tissues, even fat tissue can be used. This is the so-called poor people embolization material, is the fat tissue that we can extract from the puncture site, for example, on the femoral. But this is the old version. Nowadays, for embolization of different kind of pathology, we have specific and dedicated embolization materials, and this is very important. And we are going to see during the presentation how important it is to use the exact embolization material for the exact pathology. In fact, I mentioned already that everything is important. For example, one of the most advanced, let's say, embolization material are based on polyethylene glycol particles. In fact, these are very important steps ahead, because these kind of embolization materials, they can be squeezed, and they are let's say plastic, and they can go through microcatheters. And going through microcatheters is very important, because in embolization, in the majority of the cases, it's very important to block, in fact, the microcirculation. Otherwise, in case we are putting bigger embolization materials, there is a high probability of recanalization, so that the job not to be done. And with the polyethylene glycol-based microparticles, charged or not charged by drugs, it depends on the pathology, much less probable to have recanalization of the tumor feeding channel, or AVM malformation, and so on. So this is very important regarding probably one of the most frequent target for embolization is the primary hepatic carcinoma. HCC is one of the most frequent target for this procedure. And for this procedure, there are very, very important part of the procedure to be on the proper way. I mentioned already there are also relatively old practices, like uploading the drug that we want to selectively go to the tumor in lipiodol, for example. This is the old version. But in fact, the TERUMO live pearls are the golden standard to have better tumor response. So this is very crucial. So what does it mean, tumor response? It's not only shrinkage, it's not only partial effect of the drug, but the complete tumor response is related to all the tumor mass. So this can be done with small particles, like the particles that TERUMO is producing, because they are based on polyethylene glycol. And because of this composition of small particles upload the drug can reach with slow release inside the tumor, inside the microvasculature of the tumor, and this is crucial. The live pearl is nowadays the golden standard. It's uploaded, as you see, in saline. In fact, 2 milliliters of live pearl particles uploaded in 4 milliliters of non-pyrogenic saline. And to this combination is added the drug, the chemotherapy drug, and also some contrast in order the embolization to be visible. And there are multiple trials and huge experience with LivePearl, including in our situation. We have many cases performed with the LivePearl, especially for primary hepatic carcinoma, mainly with epirubicin. That is the modern version of the old doxorubicin. And we are, because of, with this reason that I mentioned, we are utilizing the LivePearl as a routine practice to have good, efficient, with complete response of the tumor to the embolization. Veloso Gomez published a very big series of drug-eluting embolization for the TACE, and definitely comparing to the conventional TACE without the drug loading the particles, obviously, and let's say naturally the results are much better with the drug-eluting particles in this situation, because there is a combination of lack of perfusion and drug itself. So the cytostatic is, let's say, brought directly inside the tumor mass. And because of that, the result that both visual and clinical results are definitely in favor of the drug-eluting version of the embolization. BioPearl, in fact, is the last, this is on the top of the wave, the last invention by TERUMO regarding the TACE. And what is the difference from LivePearl? The difference is that the BioPearl, in fact, the particles are the first in the history resorbable. What is the reason? What is the rationale behind the particles to be resorbable? It's definitely very important to emphasize that in many of the cases, more than 60% of the cases, the embolization has to be repeated 2 times, 3 times. And in case we completely stop the perfusion of the tumor for a long time, for more than 30 days, there is in fact the probability the organism of the patient to elaborate collaterals and to stop the access to the tumor through the main feeder. So more or less, the reason is we need, as a secondary or third procedure, we need the main feeder to stay patent in order to have second or third access directly to the tumor in order to finish the job. So this is the rationale behind the bioparticles. So these are the benefits, like mentioned here, for super selective taste. So I mentioned several times that super selective is crucial, and in fact this is the nature of super selective embolization in order to avoid systemic collateral effects of the cytostatic. We have to have super selective access to the tumor feeder. And such with bioresorbable particles, we have real access, direct access to this super selective vessel that is supplying the tumor. And especially for small tumors, this is absolutely crucial. And for people with a liver disease, because the majority of these people, they have, before the tumor, they have another disease like cirrhosis, like intoxication. So it's important to keep untouched the other part of the liver in order to allow the patient to have restoration of the liver function. In case we are not super selective, this will be not true. So the drug will damage the function of the liver as an organ, and we don't need that. We need super selective application of the drug that are loaded inside the particles with slow release inside the tumor mass and sparing the surrounding tissue. So this is very, very important. So we are preserving the compliance of the vascular bed, we are preserving the patency of the feeder, and we are preserving the function of the liver itself. So this is really very important for the supra-selective TACE application. And I mentioned the BioPearl, despite they are new, they are already very good data, very good scientific data and trials, showing that they help the interventional radiologists to perform standardized and probably repeated embolization procedure and limit the appearance of compensatory blood vessels, the collaterals that are, in fact, we don't need them. This is the product itself, and there are several slides showing how during the time the BioPearl are resorbed. They are, in fact, these are showing how step by step the size of the pursa is going down, and finally they are resorbed by the surrounding tissue. Several cases. This is a case performed with a BioPearl. With this relatively small target zone, you see, especially for small tumors, it's very important to choose the right small vessel that is supplying the small tumor. And during the time, you see that after the first procedure, there is a total stop of the supply of the tumor, but during the time, there is a step-by-step revascularization of the feeder in case we need a second attempt. And in this graphic is very well shown how important the sustained chemotherapeutic drug release, especially using with this technology. And the systemic, how low is the systemic concentration of the drug. So we don't need the collateral effects of the cytostatic drug. And because of that, the systemic concentration has to be the lowest possible. That is, in fact, provided by the super selective application of the materials, such like a BioPearl. And this is another case showing the embolic effect, and after that, the restoration, the natural flow restoration after a certain time. I wanted just to spare time to show how important another zone, another vascular zone. This is the zone of glomus caroticum tumor. In fact, one of the biggest problem with the glomus caroticum tumor is the bleeding during operation, during surgery. So it's since long time ago we are helping our colleagues, the surgeons, neuro and vascular surgeons, to have less bleeding, because the glomus caroticum tumor are extremely well supplied. And because of that, we have to embolize before the surgical approach. We have to embolize the glomus caroticum in order to reduce. In fact, there are two reasons. First, to separate the glomus caroticum tumor from the tissue of the carotid artery. That is, in the majority of the cases, the glomus caroticum tumor is surrounding the carotid artery. So to have good separation, vessel from tumor. This is one. And the second one is to reduce bleeding. And because of that, the second step, the surgery itself, has to be performed within 1 week after the embolization of the glomus caroticum tumor. And to be fair, it's not a piece of cake. So it's easy to embolize the glomus caroticum, but it's very important to protect the brain of the patient, because even we are super selective into the feeder of the glomus caroticum tumor. We have to pay attention that this feeder can have, for example, pharyngeal artery and occipital artery, can have a collateral flow and connection to the vessel supplying the brain. So this is very important before starting the procedure of embolization itself, to pay attention to all interconnections between the supplying the tumor vessels and the vessels that are supplying the brain, because the result for example, in this case, the result can be devastating. So in case of help our colleague surgeons, we can damage the brain of the patient with the most dreadful complication that can be, of course, the stroke. So everything is a matter of innovation, material, but also practice. So we have to have the exact practice and the exact vascular territory in order to achieve the right result. As a take-home message, the primary objective of advanced days is to prolong the life of the patient. In fact, this is the first number one target of the medicine, to prolong the life expectancy of the patient and to have a complete response of the pathology that we are embolizing. So in the majority of the cases we are embolizing pathologic formations like hepatic or glomus caroticum or arteriovenous malformation. And because of that, for all this very versatile kind of pathology, we have to have good vascular preservation of the surrounding tissue. We have to have the exact size of the particles and the exact catheters, and because of that the catheter that we are using is also very important. So the exact catheter, we have to have notion the particles that we are using, what kind and what size of catheter they are requiring, because it's not all the pearls are the same. Like I mentioned in the beginning, the majority of the particles that are simple plastic, let's say, they are not squeezable like the live pearl and the biopearls, like these polyethylene glycol particles by TERUMO, and they require bigger catheters. So we have to have in notion what are the materials that we need for the particular case. And thank you very much for your kind attention.
Perhaps a short question concerning embolization treatment in the liver. This is a very special organ because we have two circulatory systems. We have also the portal system. Does that influence the outcome?
Definitely, it's a very crucial case. For example, with patients with total portal vein occlusion, we have to be very cautious because, in fact, in case we don't have the flow by the portal vein and we embolize a too big territory by the arterial supply, in fact, we are stopping the two options for supplying the liver. And instead of helping, we can kill the patient by the embolization. So we have to pay attention to have at least partial patency of the portal vein. This is very important.
Yes, are there any questions? If not, thank you very much again for the overview you have given us. And we proceed in the program. The next talk is dedicated to endometrial carcinoma, bleeding. Not here. Oh. Then, yes. I don't know if... Yeah, then we have now time for a coffee break. Yes, so for 20 minutes, then we go on with the program. Enjoy the break.
So help me hear the birds.